So now that we've discussed the basic clinical manifestations of increased ICP, let's discuss some potential interventions. So the first thing we're going to be discussing in our interventions is what position are we going to place the head? The head of the bed is very important. Generally speaking, when you're talking about nursing interventions, you want to begin with the least restrictive. The non-pharmacological intervention typically goes first when they're asking you what's your initial response, your initial intervention. Okay? And so we have to discuss the head of the bed. And should the head of the bed be elevated or lowered? I hope you guys said elevated, but generally speaking, the head of the bed has to be elevated, because as the head of the bed is elevated, this is the brain, okay, this is the skull right here, the elevation of the head will promote venous return to return downward. Putting the patient's head flat will increase the pressure. So always remember that you want to keep the head of the bed elevated to ensure cerebral drainage, adequate cerebral perfusion, and that's going to help avoid complications that we discussed previously. Another thing, generally speaking, is talking about education, okay? So keeping in mind this whole idea of keeping the head of the bed elevated to reduce pressure in the head to promote venous return, you want to educate the patient into avoiding certain activities that would increase the pressure in the head, that would lower the head below the level of the heart, below the level of the waist. So it's going to include elements like do not tie your shoelace, because you bending over to tie your shoelace is going to increase the pressure. Do not pick things up off the floor. Utilize some type of, I don't know what it's called, but that long plastic mechanism that grabs things and lets them go. You want to utilize those things perhaps in lieu of bending over and grabbing those things, because of the issues with head of the bed, with keeping the head of the bed elevated, or just keeping the head elevated in general. Keep in mind that NCLEX is not going to tell you the specific thing that we're discussing. It's not going to ask you, it's not going to use a verbiage that you see in the book specifically. It's going to provide you with the foundation, which I'm trying to elaborate on right now, and you guys have to utilize your critical thinking to put these things together. Another thing that you're going to be discussing with your patient is the contraindication to coughing. Sometimes ICP may develop post-op. If the patient had some type of surgical procedure that required us to go have an invasive procedure of the skull, well, secondary to any type of invasive procedure, there's edema, there's inflammation, there's swelling. And so the patient's edema may be still elevated in the brain. So because of that, we tell the patient to not cough after the patient had some type of brain surgery because of the issues with ICP. This education is carried out before the surgical procedure, but nonetheless, it's something that we're going to educate our patient about. Continuing with education, you also want to educate them about not straining when it comes to defecation. The patient doesn't want to strain, because we discussed Cushing's triad, and we discuss bradycardia, bradypnea, and a widened pulse pressure. Well, if the patient strains, if they're trying to defecate, if they're constipated, if they're having a hard time with their defecation, if they have hard, dry stool, at this point, they're going to strain and they're going to they're going to perform what we call the Vasavas Maneuver, or we're going to be activating the parasympathetic nervous system, and that will exacerbate the bradycardia. As you guys know, that when you strain, you have the vagus nerve that comes from the brain all the way through the airway, the thoracic area, the GI tract, all the way down to your anus. So when you're constipated, you're activating the parasympathetic nervous system, and it's going to drop the heart rate. And because of that, it's also going to increase pressure on the head. So want to avoid straining. And to do that, your initial intervention would be to increase fluids. And right now I'm just discussing how we prevent straining, because the patient that has increased ICP, the doctor may give parameters to not increase fluids too much because of the retention of fluid, if that's the etiological factors within the ICP. Okay, so just keep that in mind. Right now I'm just talking about how do we avoid straining independently, right? So you can increase fluids, but of course, if the patient has any fluid retention of the brain, that's going to be a contraindication. But we also want to increase roughage or increase fiber in the diet, because increasing fiber in the diet will promote more water being absorbed into the intestinal tract, which will help with the formation of feces, and it will help not strain when the patient's defecating. That's what we have to know about. We have to do our patient teaching on. And now let's talk about some pharmacological interventions. So when it comes to straining, the patient can receive stool softeners. Okay. In regards to medications to reduce that pressure, the number one drug that we're going to be giving is known as Mannitol. Mannitol is an osmotic diuretic that usually gets rid of fluids or excessive edema anywhere in the cephalic region. So we can give it for both brain issues or ocular issues or even inner ear issues. But right now we're discussing Mannitol for the purpose of reducing cerebral edema, for the reduction of cerebral edema. Okay. In some cases, we could also give furosemide or Lasix, but generally speaking, this is the one that we're going to be giving, Mannitol. And lastly, when it comes to medical interventions, we could also give corticosteroids. Now, the reason behind giving corticosteroids is because they're powerful anti-inflammatory drugs. And if the patient had some type of injury to the brain, or if they're having a CVA, or any type of issue that causes brain or cerebral edema, those corticosteroids will be sufficient or efficient in reducing the cerebral edema as well. And that goes for your medical interventions, right? But for your pharmacological interventions. But then, sometimes that's not enough. And we need to perform some type of emergency intervention to reduce the edema. At that point, we're going to be discussing surgical interventions. And some of the surgical interventions that we're going to be discussing is either a craniotomy, which is when we create holes within the skull at various locations so we can reduce or help evacuate some of that excessive edematous fluid, so the pressure won't be consistently piling within the cranial vault. So we can do a craniotomy, or we can do a craniectomy. Keep in mind that for a craniectomy, we remove a portion of the skull. Let's say we remove this part of the skull. Patients who are post-craniectomy, keep in mind that they're going to have the surgical issue up here, but they're also going to have a surgical incision somewhere in the thoracic or the abdominal cavity, because what we do is we remove that piece of cranium and we create a surgical incision and we tuck it inside within the body so the body's blood supply can innervate with the blood cavities or the sinuses within the cranium, so it can maintain perfusion of that cranium. And once the edema subsides, then we hopefully place it back. So keep in mind, for your post-op craniectomy patients, you're going to be dealing with two potential surgical wounds. The one up top in the cranium where they remove the skull, and also the part in the abdomen where they're tucking in that particular piece of cranium so it can maintain its perfusion and so it won't die off and then we won't be able to put it back. Okay? So essentially, those are going to be your main nursing interventions. Keep in mind that you want to also monitor for any indications of seizures, because when people have ICP, we discuss Cushing's triad, we discuss the neurological issues. Patient's level of consciousness will change. Make sure you guys monitor your patient's level of consciousness every 15 minutes for the first hour or so when the patient's post-head injury, because we don't know if it's manifesting later on. I had a patient who, at the close to the end of shift, 12-hour shift from 7 a to 7 p, at around 6:30 or so, the patient was found on the floor. I did a thorough assessment. I noted a head injury. Something happened during night shift. The patient was transferred out, and en route, the patient passed away because of ICP complications. That's how sensitive this is, folks. So it's important that you guys monitor your patient for any changes. We discussed the fluctuations of blood pressure within time span so we can identify any widening pulse pressure. You're also going to be monitoring the patient for any other issues like nausea and vomiting. We want to medicate accordingly, because nausea and vomiting will also increase ICP, which will exacerbate the condition as well. Okay? I hope this helped out, guys. Please follow me at Learn NCLEX now and tell your buddies about me. Thank you.